Good morning and welcome to our Voices 19th Anniversary Remembrance Symposium and our presentation on grief, loss, and pathways to resilience with Dr. Christy Dinkla, Kathy Shear, and Steve Koza. My name is Mary Fetchett and I'm founding director of Voices Center for Resilience. I want to begin by recognizing our very generous sponsors who've made today's event possible. Our presenting sponsor, Turk and Heath and McCauley, our leadership sponsor, the Deary Law Firm, and our legacy support sponsors, Kreindler Law Firm and Motley Rice, and our benefactor sponsors, Spicer Krause, Barish McGarry, Hanson, and Rosasco. A very warm and sincere thank you. So I want to begin by introducing our first presenter, Dr. Christy Dinkla. Dr. Dinkla is a clinical psychologist with joint appointments as a research associate in the Department of Epidemiology at Harvard T.H. Chan School of Public Health, a research fellow at the Stanley Center for Psychiatric Research at the Broad Institute of MIT and Harvard, and an instructor in psychiatry at Massachusetts General Hospital, Harvard Medical School. Her work aims to understand how adversity affects mental health and well-being across the lifespan, with a particular focus on bereavement. Dr. Dinkla completed her postdoctoral fellowship in psychiatric epidemiology at the Chan School of Public Health and her clinical psychology internship at Mass General Hospital. Her doctoral research was completed at Adelphi University in New York City. So I'd invite Dr. Dinkla to join us now. So thank you for being with us today. And in this COVID environment, and certainly after so many of the tragedies that have occurred, since, of course, our founding, 19 years ago, we're really looking forward to hearing your presentation. And so I'll turn it over to you now.
Okay. So thank you so much for that introduction. And I'm really honored to be here to talk to the audience, and especially on behalf of Voices, which has done so much to support survivors. And I'm eager to talk about resilience, especially in the context of this kind of augmented mission that you spoke about, Mary. And when I was preparing for this talk this morning, I thought, what outcome would I really like to see from this talk? What would I like to see come out of sharing some of what I have to say today? And the main thing that I hit on was to share with the audience some information to demystify resilience. Resilience has become a very popular term. It's a common term. We hear it all over. We hear it in schools. We hear it in mental health centers, but we're also hearing a lot about it in the media, and we're hearing a lot about it in the context of COVID, as we ask ourselves on a global level what it is to be resilient in the face of extreme challenge. So the reason that I would like to demystify this is because I think an outcome of some of the popular use of resilience has been some confusion and some unintended consequences, such as increased stigma, such as people experiencing stigma or sense of failure if they feel that they are not resilient. And so one of my main goals today is to share some information so that this is demystified, such that resilience, to clarify that resilience is not necessarily an individual trait that is, it certainly includes personality, but it is not just a trait of extraordinary capacity, of extraordinary well-being, but rather it's a process. And I'm going to give some information today to explain or some of what I've learned from my own research about that process. So just to start, to set the context, especially this audience probably needs no orientation to this, but bereavement or loss of a loved one is a near universal experience. At some point in the lifespan, we are all likely to lose someone we love. And I imagine this audience is familiar with this experience. Bereavement is interesting because it is a model to understand risk and resilience to trauma across a lifespan. Um, and so today, what I'll just be talking about quickly is some of what we know about risk and resilience, some of the pathways to resilience, some of what we've learned. And then I'd like to leave you with some kind of practical clinical applications or practical life skills, or what we know about things you can go home and apply right now in terms to increase resilience. So we know that there are some factors that increase risk for complications after loss. Now, these complications, when I speak of them, I generally speak of mental health complications. So these can be difficulty with well-being, difficulty or increase in mental health symptoms. And some of these things can be related to individual factors, like a prior history of depression, a prior history of loss or trauma. And we certainly know that compounded losses increase risk for deficit for mental health symptoms after loss. Some of these can be relationship based, so the quality of the relationship, the closeness, the identity, and that was with the lost loved one. Some of these can be circumstances around the death, so that the age of the person, how they died, and how they died. And this very much relates to the lifespan model in the sense of on-time and off-time loss. So there are sort of off-time losses, which would be unexpected losses. So these can be losses of a child as a parent, losses of the loss of a baby or in utero, and or loss of a spouse at the younger ages. And then there are on-time losses, not such that. So these are losses that are experienced sort of aging parents when they die. So these are all very different sort of circumstances around the death that can impact how people, what people experience after. And then there's the context of the death. So this can be, what is going on in the bereaved person's life at the time of loss. We know that this has a lot to do with how people respond to the loss of someone they love. And then there are consequences of the death: loss of income, the need to move, loss of social connections. And we're certainly seeing a lot of this with COVID. I think one thing we are learning from COVID is the dramatic effect that sort of social determinants have on the experience around the death of a loved one. So quickly, I'll talk about some of the risk factors, is specifically in terms of parental bereavement, just because that's what I have focused on most recently. So this is sort of this lifespan model, and we're showing loss happening for children who lose a parent, which would be considered an off-time loss. Some of these there are psychological consequences. Prior work has shown increased risk for depression, post-traumatic stress disorder, chronic grief, substance use, neurocognitive deficits. There are biological consequences that have been documented in studies, such as cortisol abnormalities. So this is the stress hormone, reproductive health problems, and even metabolic syndromes, such as increased risk for obesity. And then there are social adverse consequences of parental loss, such as decrements in academic functioning. So this is difficulty, impairment in school functioning, and even impairment in the work, in professional competence in the work. So what this suggests is that these early losses in childhood can have adverse effects that really play out across a lifespan into adulthood and even much later. Given what we know about these adverse effects, we also know that not all who lose loved ones, especially not all children who lose parents, experience these adverse effects. So this leaves the question, it presents the question, could people possess the inborn ability to adapt to loss? And if we do, what is that process? And why do some people go on to experience some difficulty, and some people appear not to manifest with those same difficulties? And this is really sort of the seed of resilience research, is what is it that is going on to promote this adaptation or this recovery process or this resistance to psychiatric burden. And that's this diagram here to show that this there is a potentially a fluctuation of well-being, and there's a process over time that unfolds potentially. This is our hypothesis or our theory about this adaptation to loss, which is characterized by episodes of well-being, episodes of difficulty, but there is over time a balancing, which we would call adaptation. So this is some of the epidemiological research on exposure to parental loss before 18. This is before COVID, obviously, and we expect to see much different numbers. I would suspect after COVID. And the important part of this map is just to show that exposure to parental loss ranges from about 4% to upwards of 11%. So at the lower rates around in states like California or parts of New York, about 1 in 20 children will lose a parent before the age of 18. But in states like West Virginia, they can be much higher, upwards of 11%. So that's nearly, a little bit more than 1 in 10 children. So given that this loss is frequently experienced or experienced in at least 4 to 10% of the population, then what do we know about how people respond? And this has been some of the early work of George Bonanno, who has done a lot to describe the phenomena of resilience, and he's done this by looking at people across time. So one of the difficulties of studying resilience over time to loss is that it's very difficult to know how people were doing, at least in the data anyway, before the loss. And that can really affect how people are doing after. So when he started doing some of this longitudinal work and following people over time, what he found was that most people, and this proportion ranges anywhere from 40% to 60%, even upwards of 80%, depending on the type of trauma. Most people seem to do fairly well after they have experienced some type of traumatic exposure. And so the question has then become why? So are there protective factors at play that can reduce or attenuate some of the adverse effects of loss? And we have found some of these things through research that identified several of these factors. They can be person related. These are sort of personality traits such as hardiness, flexibility, having a coping repertoire, continued bonds with the deceased. Relationship-based, these can be things like social connection, social support, social cohesion. And I have to say that of the research that I'm familiar with, this is some of the strongest evidence for factors that can promote adaptation or resilience to loss. Circumstances of the death, whether there was end-of-life planning, the developmental timing of it, this idea of having on-time and off-time losses. Context of the death, if there is a lower trauma burden at the time of loss, it can facilitate recovery if it's sort of intuitive. And then consequences of the death. If there are massive consequences of the loss of the loved one, that can cause more difficulty or increase risk for impairment. So we get to this question of defining resilience. And this is actually a definition from the American Psychological Association, which is from 2014, which is the process of adapting well in the face of adversity, trauma, tragedy, or significant sources of stress. Now, this definition has not changed much since the 70s, since Garmezi started first writing and doing some of the earliest research on resilience as we think of it today in the context of childhood development. And this is, however, there are several problems with this definition. One of the problems with this definition is that we know that factors associated with resilience operate at multiple levels. It is not simply an individual-based factor. So we know that biology can play a role in response to stress. Psychosocial systems can. We are seeing this especially in COVID now, where a socioeconomic status is determining not only exposure, but also incidence of COVID, and then the consequences of COVID in terms of job loss. And then the social environment is a major factor in how people are able to buffer against the adverse effects of loss. There's the built environment, and then there's even the natural environment. We've seen hurricanes in the South, and these are certainly compounding stressors in situations where people are already coping with high COVID rates. So there are more concerns with current definitions, including resilience is it's defined differently in different studies. Should it only be considered in the aftermath of a trauma, given that stressors are nearly ubiquitous? Should it be considered as a property of social and political context rather than individual traits? And again, I think COVID is really highlighting this in that resilience or being able to bounce back from adverse effects is not simply a property of the individual. It's not simply a property of superhuman strengths, but also about the social environment and social policy and social well-being that can buffer against, give people a buffer against a cascade of adversity after exposure. And this has been a particular focus of my research, which I'll talk about in the next few minutes. Asking, is all resilience is all resilience adaptive or good? And I've found some evidence to suggest no. And I'll go through those quickly. This is some early research on dependency. Dependency has typically been considered a risk factor for, was a personality disorder, a risk factor for psychiatric disorder. And what we found was actually when we looked at dependency more carefully in terms of its adverse effects versus its adaptive effects, the ability to reach out to others and to seek support from others can actually be very protective in the aftermath of loss. And this is in fact what we found after among spouses who had lost a loved one. So this a trait that had sort of been considered a risk factor for psychiatric disorder could actually be protective in some contexts. We found similar dynamics looking at a sample of in South Africa, a sample of Xhosa-speaking women who were from living in Cape Town, which is an area of high social adversity and lower socioeconomic status. And when we looked at women and we looked at their neurocognitive function among women who had experienced exposure to childhood abuse, what we found was that women who actually had some lower, poorer performance in some neurocognitive domains actually were doing better in terms of daily life skills. So for example, women who reported high quality of social relationships actually reported lower or demonstrated lower nonverbal memory in neuropsychiatric tests. Similar with work functioning. So women who reported that they were doing well in occupational settings actually demonstrated lower nonverbal memory, slower processing speed, and lower semantic language fluency. These results were unexpected and not intuitive, but when we interpreted them in the context, it started to make more sense because in context with high adversity, high daily exposure to adversity, some slowing of processing speed might actually facilitate the capacity to engage in activities of daily living, which can then support well-being. So taken all together, when we think about this in sort of more pragmatic terms, what we see is that flexibility and is one of the core components of psychological resilience. So the capacity in the moment to appreciate the environment, appreciate what needs to be, the demands of the context, and the ability to select a strategy that is appropriate for that context or to carry out or to achieve an end is potentially a more accurate definition of resilience rather than a fixed trait that is that proceeds regardless of the demands of the environment. So in terms of some sort of practical applications of this research, we can turn to some early work of Anne Maston, who found through her work that there were sort of five domains that were associated with with resilient functioning. And some of those we've covered already, so a lot of these will be familiar, but these are cultivating and expanding social network and important relationships. And this is some of the core work of Voices, which is to provide that social safety net to exposed individuals. And this is such a core factor in not only buffering against psychiatric disorder, but also in promoting well-being. A second is supporting agency and mastery. And this is the idea of being being effective in the moment. For example, we've perhaps all faced large projects that feel overwhelming and can increase stress, and it's hard to know where to start. And so instead we might, I'll speak on I might clean the house rather than actually do the project. But if I can select one action item of these overwhelming project, then that increases my sense of agency and mastery and well-being, and then actually supports the execution of effective actions that lead to the completion of that task. Third is fostering regulation, and so this can be these are some sort of internal skill-based techniques to buffer against stress. And then the fourth might be nurture faith, hope, and meaning making. And there's some really fascinating research coming out of the flourishing field about how critical these activities and these engagements in faith, hope, and meaning making can buffer against adverse effects. And then the fifth is building problem-solving skills. And all of these are somewhat interacting and overlapping, but these are some of the most common themes that have appeared throughout the resilience literature, especially from childhood development, on factors that can promote well-being and facilitate that adaptation process. So in conclusion, I just say thank you to my some of the funders for my research, and thank you to mentors and research assistants and the K mentorship team. And then this is my contact information if anyone has further questions or would like to follow up on any aspect of what I talked about today. So looking forward to the questions, and I will sign off here and turn it over back to Mary. Thank you.
Thank you, Christy. It was really such a fascinating follow-up to Dr. Figley's presentation earlier this morning. So I'm looking forward to some of the questions and further discussion. Next, I'd like to introduce Dr. Stephen Koza. Dr. Koza is a professor at the Uniformed Services University, where he serves as Associate Director at the Center for the Study of Traumatic Stress, and he's a director of the Center's Child and Family Program. Dr. Koza is a diplomat of the American Board of Psychiatry and Neurology in the specialties of general psychiatry and child adolescent psychiatry, and a distinguished fellow in the American Psychiatric Association. Dr. Koza's professional interests have been in the area of clinical and community response to trauma and the impact of deployment and compact injury, illness, and death on military service members, their families, and his children. He was instrumental in organizing and facilitating the initial mental health response to the September 11th attacks on the Pentagon, and he studied the impact of sudden and violent death on the health and well-being of family members of bereaved military duty-related deaths, as well as deaths due to terrorism. Dr. Koza and I met, actually it was through one of our other presenters, Dr. Kathy Shear introduced us when we had received a grant from Public Safety Canada to conduct an extensive research project on the long-term needs of victims' families. And I have to say it was a marriage made in heaven. It was just such a wonderful opportunity to work with Steve. And he's going to be sharing some of that information today. So I'm going to invite Steve to come up and start his presentation.
Thank you so much, Mary. It's really a pleasure to be here and an honor to be sharing the podium with my colleagues. And I look forward to the presentation and discussion today. I'm going to go ahead and share my presentation. As Mary had mentioned, this is a presentation that will be talking about research that we collaborated on and conducted over the past several years and have been analyzing the data for over the past couple of years. I do want to start by drawing people's attention to the sculpture that was done by Stephen DeStabler. I don't know if any or many of you know Stephen DeStabler. He was a sculptor from California who worked largely in the Bay Area and was someone who stayed involved with art related to the human figure for some time, despite the fact that there was a movement towards abstract art back in the 1950s. One of the things I find extremely poignant about his work is the way he treats the human figure, constructs and demonstrates the fragility and also the resilience of the figure. I'd learned after I had come to admire his work for some time that his mother had died when he was a teenager in an airplane crash in a cornfield. And part of the work, in fact, part of this particular series of winged objects that he did was a reworking of the bereavement and the trauma that he experienced and the reconstruction of his memory of his mother. And again, I find it an inspiring piece and appropriate for our discussion today. Okay. So I do want to mention that I'm from the Center for the Study of Traumatic Stress at Uniformed Services University. For those who are not familiar with Uniformed Services University, it's our federal medical school that sits in Bethesda, Maryland on the grounds of Walter Reed National Military Medical Center in a large federal healthcare complex that includes the NIH, National Library of Medicine. The centers has been in existence for over 30 years. Its main focus is examining the impact of trauma and stress on individuals and communities. We are a military medical school, so much of the research and education that's done is around military trauma, but also the center has been involved in trauma responses and study of traumatic exposures in the United States, civilians and military. Much of our work has also been associated with bereavement. We've conducted 2 large studies. One, the National Military Family Bereavement Study, was the first large systematic study examining the impact of bereavement on military family members. And then Stepping Forward in Grief, which was a follow-on study that was conducted in collaboration with Dr. Scheer, examining the effect of two online virtual programs designed to support grief integration. And we've consulted with groups like Sesame Workshop and products that they've put together. One related to when families grieve, program materials for families with young children when there's been parental loss. And more recently, we do have many fact sheets on our website, but more recently have focused on some of the losses associated with COVID-19, the challenges associated with those particular losses, the importance of principles that should inform how we notify those family members, and some of the unique challenges associated with COVID loss. And again, these slides will be shared, but you can see the website at the bottom for the center, and please feel free to access that and look at the resources that we have. Part of our work at the center has really been a focus on this, the area of sudden deaths. And sudden deaths include things like accidental deaths, suicides, homicide, combat deaths, disaster deaths, terrorism-related deaths. And this, in fact, led to our collaboration with Mary Fetchett and Voices of September 11th, Sudden deaths are unique in the sense, and this kind of springboards off of Dr. Dakla's comments earlier, that they're unexpected and often involve the untimely deaths of young people. In addition, they often involve violence that can make it much more challenging in the bereavement and grief integration, and therefore can lead to greater risk of negative bereavement outcomes in the survivor population. There have, in fact, been fewer studies on terrorism and the impact of terrorism on bereavement. There have been a few studies, but not many, and certainly not studies that have examined the population long-term. And we know that terrorism adds even greater risk because of the criminal nature associated with it and the human culpability that can result in anger and bitterness that can complicate grief integration. So this interest and the connection with Voices of September 11th led to this study that we conducted, Bereavement Due to Terrorism, which was a collaboration not only with Voices, but also with the Canadian Resource Centre for Victims of Crime. And the goal was to examine long-term post-loss outcomes of those that were bereaved by terrorism. We collected our data a couple of years ago and included family members who had lost loved ones due to 9/11, and then also those family members who lost loved ones due to the Air India Flight 182 attack, which was over 30 years ago. I'm going to be speaking about the September 11th data today. The aims were really to examine long-term bereavement outcomes that follow terrorism, and then to identify predictors of those outcomes, to develop preliminary working models so we would better understand what leads to risk and protective factors for family members that might be specific to terrorism-related deaths, and then build the basis for ongoing research to inform training and counsel for disaster and terrorism victims and their families. This was our design and methodology. So family members of any kind, that were spouses, parents, in-laws, cousins who were bereaved by either of those events were at least 18 years old, English speaking, and since this was an online questionnaire we asked people to complete, they had to have access online. Participation was anonymous and voluntary, and there was no compensation that was provided. And we examined a number of constructs. We asked demographic information. We asked information about the characteristics of the death, the cause of the death, questions about remains, religious consequences, availability of post-death resources. So how were family members doing financially? Did they receive grief support? Did they require mental health care or receive mental health care? And what were their social supports like? Media involvement. To what degree was media involved in describing the events that led to their loved one's death? How accurate was that information? How intrusive? And were they respectful of privacy? We collected information about memorialization, and then importantly about current psychological functioning. So were they still endorsing symptoms consistent with significant grief severity, depression, anxiety, post-traumatic stress disorder, post-traumatic growth, and a number of other areas of functioning. And then we asked about interim life events. Since it had been so long since 9/11 had occurred, what kinds of events had occurred during that course of time, and how were those events perceived, either positively or negatively. I won't be able to share all this information, but I'll talk about some of what we did. So one of the analyses that we conducted was to examine patterns of comorbidity in participants. And what I mean by comorbidity is, to what degree did individuals who completed our questionnaires 15 years after the death of their loved ones in 9/11, were they still endorsing symptoms consistent with a diagnosis of depression, complicated grief or prolonged grief disorder, anxiety disorder, PTSD. The studies that have been conducted looking at terrorism-related deaths are mostly look at the short-term effects. So we saw this as an opportunity to really see how people were doing over many years after the death. We anticipated, based upon the literature, that the majority of individuals affected by traumatic loss were likely to integrate that loss and adapt to the loss. But we also understand, and Dr. Dekla mentioned this, that there's a negative synergy that occurs between trauma and grief. So those who've had traumatic experiences either prior to or after the loss, it can complicate their functioning and can worsen grief severity. In addition, studies that have looked at clustering of symptoms in those who have been affected by bereavement, whether it's been traumatic bereavement or not, have tended to be looking shorter term. And then they've also looked at symptoms rather than disorders. So we were really much more interested in looking at how to characterize the diagnostic profiles of people who were engaging in this study with us. And so this resulted in a paper that was published last year in the Journal of Traumatic Stress. And these were our predictors, again, that the majority would be healthy, but we did anticipate that comorbidity would vary. And those with comorbid complicated grief and PTSD would likely have higher impairment associated. And as part of this process, we were interested in looking at the risk and protective factors that would predict membership in one or other of the groups to which the participants were assigned. These were our participants. We had 454 individuals who participated in this analysis. Their age was in the mid-50s, largely a female and white group of participants. About 40% were spouse partners, but we also had about a quarter were siblings and about 20% were parents, and the remainder were children and others. We asked where their loved one had died and where they were located. And we found that about 90% of the participants had loved ones who perished either at the World Trade Center site or were in the plane that hit the World Trade Center. And then we similarly had representation, but smaller representation for those who died in Shanksville or at the Pentagon. The participants themselves lived in a variety of different areas, but the majority were either in the 5 boroughs of New York City or the New York City metropolitan area, and about 30% were in other areas around the country. So broad representation. So when we try to understand the patterning of how people are responding, the way we do that is use an analytic process called latent class analysis, which is a statistical process that tries to group people together that have similar characteristics. And the characteristics or the indicators by which you determine or you ask how they're linked together are important, because that then kind of tells you, okay, these are the characteristics that are shared across the group. What we were interested in as indicators were meeting threshold for certain diagnostic criteria. So it was complicated grief, post-traumatic stress disorder, depression, anxiety, and then also grief-related functional impairment. So we were looking for people who met threshold for some level of significant clinically significant functional impairment based upon the work and social adjustment scale. So in the analysis, the best fit that we found statistically was a 3-class model. And what that means is that all participants essentially were grouped. All participants were categorized into one of 3 groups based upon their probability of meeting threshold for those different criteria that I just mentioned. If you look at the green bar at the bottom of the slide, you'll see that about 2/3 of our participants formed a healthy and resilient group. If you look at the dot and slash line that runs across lowest to the x-axis, those are the people. So to orient you to this slide, on the bottom, you can see categories. Depression, meaning what probability each group had for meeting threshold criteria for depression, what probability people had for meeting threshold for complicated grief, PTSD, anxiety, and functional impairment. You can see in the healthy and resilient group that the probabilities for meeting criteria for any of those disorders or for functional impairment was either 0 or extremely low. In comparison, we had another group shown in the yellow-orange where we saw quite a bit of comorbidity, comorbidity for depression, complicated grief, and anxiety. This was a group that constituted about 20% of our sample and had a mild likelihood of having functional impairment, but not as high as the third group, which was the most impaired. Notably, in neither of those two groups, either the healthy resilient group or the comorbid no PTSD group, was PTSD present. But if you look at the red group, what we found was in that group, 90%, there was a 90% or above probability for meeting threshold criteria for depression, complicated grief, an anxiety disorder, or clinically significant functional impairment. And in those cases, we typically saw, most of the time, comorbid post-traumatic stress disorder as well. So our next goal was to look to see what were the predictors of that latent class membership. In other words, what was it that likely contributed to one person being in one group versus another? What we found in looking at that red group, the comorbid PTSD impaired group versus the healthy group, they were 13 times more likely to be parents than the healthy group, which again is not surprising based upon some of the material that Dr. Denkla shared, that these were experienced as untimely deaths and parents were struggling and were having much greater difficulty, so they were much more highly represented in that particular group. They were also 4 times more likely to have other non-9/11 trauma, whether that occurred before or after 9/11, it didn't matter. The accumulation of trauma much more likely contributed to comorbid PTSD, overall greater severity, and higher likelihood of grief-related impairment. And this group was also more likely to have negative interim life events, financial inadequacy, and dissatisfaction with available social supports compared to the healthy group. If we think about this from a resilience or a protective standpoint, the other way to look at it is that the healthy group had more positive interim life events, had adequate finances, and had available social supports, or all of which seemed to support their membership within the healthy group. We also looked at the red group compared to the yellow-orange group, and although that middle group was having some difficulty compared to the healthy group, that group also was, the comorbid PTSD group was still 16 times more likely to have parents in it compared to that other group. And again, we saw higher representation of traumatic experiences in the PTSD group versus the comorbid no PTSD group. I'll just quickly mention what we found also in looking at other components of health, the SF8 physical component score and the SF8 mental component score. The healthy group really met community norms, having mean scores around 50, which is similar to an unexposed community level response for physical health and mental health. But in that orange group, we saw a 1 standard deviation decrement in their mental health, no change in physical component score. But in the comorbid PTSD and in grief impaired group, we found a degradation both in their physical component score as well as a 2 standard deviation decrement in their mental health component score. So these are individuals that were really struggling even 14 years after 9/11. I just wanted to make note of this given our topic today of resilience, that we looked at volunteerism and advocacy in another analysis and found that 40% of participants volunteered to support 9/11 or other 9/11 causes, and volunteerism was associated with higher levels of post-traumatic growth. So that activation, that sense of self-efficacy that Dr. Dekla was referring to, we identified here in these analyses. We found also that a significant portion of people were advocating for 9/11 families, but found higher levels of PTSD in those that were advocating for 9/11 families compared to those were not advocating for families. And we were drawing the conclusion that it's through this process of volunteerism and advocacy might be a mechanism in which impacted family members find some relief in the symptoms that they might experience. It's a way to activate and be present and do things about your grief as opposed to feeling victimized by it. So just in summary, 2/3 of participants were healthy and resilient, which was good, but another third, a significant minority, continued to endure symptoms consistent with clinical disorders and grief-related impairment even 15 years later. And this is important because we need to be looking for these people in the community even now, this far out after 9/11. There are negative effects associated with non-9/11 trauma and negative interim life events. And then there's an importance of financial adequacy and social support to healthy recovery after events such as 9/11 that we need to be thinking about, as well as the potential positive effects of advocacy and volunteerism. I did want to talk very briefly about another recent publication based upon this data set that examined data that we had collected on human remains notification, grief, and post-traumatic stress. So we know that remains notification was extremely challenging for 9/11 families. Many of these families received no notification of human remains identification, and many of these families received multiple notifications of remains identification. In our discussions and review of the literature, anecdotally, we found that this was highly triggering and sensitizing to people, very activating, and could complicate their grief and making it more difficult, or could be traumatizing in terms of having multiple notifications about the death of their loved one. At the same time, there's also a literature that states to be notified or to receive a body back after the death can be relieving to a family in most cases. But in much of that research, it was the return of unfragmented remains, whole bodies, where, as in 9/11, the challenge was that many of the remains that returned, the vast majority, were fragmented remains. So we asked the question, what's the effect of human remains notification on grief severity and post-traumatic stress? To what degree does receiving notifications decrease continued questions about the death or grief severity? Does increasing the numbers of notification worsen post-traumatic symptoms? And what effect does choice to receive future notifications have on these outcomes? So the OCME, the Office of the Medical Examiner in New York City, provided the option to families at some points to stop receiving notifications if in fact they were too activating. This is a brief, in a nutshell, summary of the results that we found that the question about continued questions about the death, to what degree do you still have questions about how your loved one died 15 years later? About 50% said not at all or a little bit, but a third said quite a bit or to an extreme degree, and that having continued questions was highly related to elevated grief as well as post-traumatic symptoms. We also found that about roughly the same percentage of those in the community, close to 40%, were never notified, but that a quarter were notified once and almost a third were notified 2 or more times. And about a quarter of our participants had chosen not to receive future notifications. Receiving one notification in our analysis was associated with fewer continued questions than no notifications or 2 or more, indicating that being notified once might have in fact been relieving for some family members. But receiving notifications was not associated with decreased decrease in grief severity compared to no notifications, and receiving 2 or more notifications was associated with increased post-traumatic stress. So there was some activation and some difficulty with the multiple notifications for certain family members. Those who chose not to receive future notifications after receiving 1 notification actually described the least number or the fewest number of continued questions than of any group. So there were some who received the news, seemed to have been reassured by that, and then no longer wished to receive any additional notifications. And that those who chose not to receive future notifications after 2 or more notifications actually described higher post-traumatic stress than any other group, suggesting that people who were getting really activated decided on their own that we need to stop receiving these notifications because they're too stressful for us. So in the study, there were some limitations. This was a volunteer, non-randomly selected sample using online self-assessment surveys, and somewhat, again, we had a mostly white English-speaking females. It was also cross-sectional as opposed to longitudinal, so we're not able to determine causality. In other words, we can't determine whether grief results in severe grief results in poor social connectedness, or poor social connectedness results in higher levels of grief. So some of that needs to be teased out with longitudinal studies. I just want to lastly mention that our group has become very interested in the concept of death notification because of some of the work that we've done. We realize that many healthcare providers receive little training on death notification, so how to talk with families after a loved one has died, either in the healthcare setting or in some other situation. Unexpected deaths are shocking and stressful. And it's important that healthcare providers get training to provide clear, concise information that's empathic and culturally sensitive. This has been particularly challenging during COVID-19, when healthcare systems have been overwhelmed and we haven't had the typical relationships that we usually do with families visiting the hospital. On the right-hand side, you can see a couple of resources that you can download at your interests after receiving the slides after my presentation. I want to thank members of study team and partners, and thank you for your attention. These are 2 additional sculptures by Stephen DeStabler that I thought I would share. Thank you again, and I look forward to the panel discussion. And I'll send it back to Mary.
Thank you, Dr. Koza. Just a couple of things to add to your presentation. When we were doing our outreach, there were many people that said that they just could not emotionally manage participating in the study. So in a sense, it could be an unrepresented group that had higher symptoms of, grief and loss. The other thing that I'd mention is that the study was supported by Public Safety Canada, and they actually gave us another grant to take the study one step further and to be able to, continue to conduct interviews. And that's the basis of our tip sheets on mass violence that you're able to distribute to victims' families, survivors, responders, or mental health, people that are working in the mental health field. And then also to add that the OCME in New York City, the Office for the Chief Medical Examiner, made a commitment to the 9/11 families that they were going to continue to identify, some of the remains that they have by using, more updated DNA processes, and they're continuing that today. There's still 1,100 of the 2,753 that died at the World Trade Center families that have not been notified. So it is an ongoing process, and I have to agree with Dr. Koza. It's constantly a problem after these acts of terrorism and mass violence that people are untrained and they are making notifications to families, and then they're left without support. So that's certainly an area that I think we can continue to examine and publish on. Next, I want to introduce Dr. Scheer. And Dr. Scheer is currently the Marion Kenilworth Professor of Psychiatry at Columbia School of Social Work and Columbia University College of Physicians and Surgeons, and Director of the Center for Complicated Grief at my alma mater, the Columbia School of Social Work. Dr. Scheer has spent nearly 4 decades researching and developing successful treatments for anxiety disorders, depression, and complicated grief. Dr. Scheer is the first clinical researcher to develop, I'm going to have a problem pronouncing efficacious treatment. Kathy, maybe you can help me with that, for complicated grief, and her work in this area led to collaboration with New York State Office of Mental Health and FEMA in response to the 9/11 World Trade Center attacks. She's published more than 300 peer-reviewed papers and book chapters. She's been recognized internationally for her work in bereavement, including both research and clinical awards from the Association for Death Education and Counseling. She lectures widely, both nationally and internationally, and she has generously volunteered her time to speak, on several occasions at Voices symposiums over the years. And we're very grateful for our collaboration with Dr. Scheer. So welcome, Kathy.
Thanks so much, Mary. It's a pleasure to be here. And I guess I should also start my video. I wasn't sure who was doing that. And I am again going to share my screen and talk to you about, really, I'm going to change the focus a bit after the very elegant presentations of my colleagues, whose work also has been rigorous and elegant and continues to be in helping us understand bereavement and loss, which is, of course, very, very important ongoing work. And talk to you instead about an approach really to understanding and supporting bereaved people, which has been the focus of our work at the Center for Complicated Grief. And I will say also that these slides will be made available to you after the presentation, and also will provide information about the Center for Complicated Grief and the resources that we have there. We do have a large and growing set of resources to help people both identify, think about grief, understand grief, and also intervention strategies. So I want to start by talking about grief itself just briefly, because of course we all know what grief is, but how to understand it is not really, we don't understand it the same way. Not all of us understand it the same way. So take a minute and just answer these 4 simple questions. First of all, is grief, do you think of it as a specific emotion, or do you think of it as more than an emotion? Do you think that grief progresses in stages? There's certainly been a lot of sort of lay press, especially since COVID, sort of promoting that idea of stages. Is that how you understand it? And, and along with that, do you think that most people resolve grief? Or then another question, is it universal or is it unique to each person? Is it different for every person? And so obviously loss is universal, but grief is unique to each person. Is it unique to each person? And is it always complicated, or is complicated grief a diagnosable condition? So after you think about that for a minute, I'll tell you our answers to these questions, which is, first of all, that grief is not just an emotion. It's a natural, complex, multifaceted response. It's a sort of whole body and mind response to loss. And it's also, as I'll talk about a little later, the form love takes when someone we love dies. Another thing about grief is that it isn't ever fully resolved for many of us, and probably for everyone when we lose someone very close, especially. Rather, it's permanent. And so we're going to have to deal with that in some way as well. It certainly is unique to every person, and not only every person, but every loss that each person, each of us experiences. So I, for example, have lost both of my parents, and the grief that I experienced after the loss of my mother was not the same as what I experienced after the loss of my father. And yet, at the same time, there's a lot of uniqueness in grief. There's also certain commonalities, at least as we see it, and that's what we're going to be talking about a lot today. So the last thing, all grief certainly is complicated. That's kind of what I've been saying. And in addition to all of this, it varies over time. In the early kind of period after we lose someone, that variation is erratic and pretty unpredictable. And over time, it generally does kind of evolve and become quieter and softer. And yet, also, complicated grief is now a diagnosable condition. In ICD-11, it's official, and in the DSM, it's almost official. And I'll talk a little about that as we move forward. It's being called in both documents, prolonged grief disorder. So again, grief does not progress in stages, and it is not a form of depression either. It's different from depression. That's one of the things that our work has really focused on, and I think pretty strongly has told us that grief is different from depression. In particular, we have to treat it differently. So what we're saying is that grief is the way that we experience a meaningful loss, and that it's messy. It's not easy to kind of describe necessarily, and it's not easy to understand either fully. So that's because there are so many different thoughts and feelings and behaviors that are associated with grief, and also there are, of course, important social and spiritual aspects. I think that's one of the things that Christy was pointing out in her talk especially, but I think it came up in Steve's as well. And as I said, it changes sometimes erratically and unpredictably, and it also evolves. And it's affected by other people and by things that happen in our lives during really, and after the death, that many of which are unexpected and uncontrollable. And so that's part of why it's complicated, but also it's complicated because we have a lot of mixed feelings and confusing thoughts that are very, very natural during the early phase of grief, and even the early period after someone dies, and even going forward. These can come up periodically, kind of sporadically. So one of the things is that we recognize grief as connected, very strongly connected to the love that we experience for someone. And so we kind of want to honor it. We kind of want to hold on to it and honor it. And yet it's painful and we want it to be over. But even the pain, in a way, we welcome it as a way of paying tribute to the love that we feel. But again, it's not very comfortable and we want it to go away. So similarly, we want to go on with our life, but it's hard to see how we're going to do it, or even to have a lot of enthusiasm for that. We need other people. This is something, again, that harkens back to both Steve and Christy's presentations. But interestingly, almost everyone has trouble feeling connected to other people, especially in the immediate aftermath of an important loss. We know, of course, that a person died, but we sort of can't comprehend that reality. It takes a long time to comprehend it, and sometimes we always feel a little bit sort of sense of disbelief about that. But certainly in the beginning, we feel that. And it's one of the reasons why these stages that, especially the Kubler-Ross stages that have as an initial response, denial, there isn't any, people don't almost never deny the fact that the person is gone. Occasionally we do see that, but it's very, very rare. But they do have difficulty. We all have difficulty comprehending that reality. And so these kinds of sort of mixed feelings and confusing thoughts, these are really examples. There are other ones as well, can be troubling to people, but they are very natural. So how do we understand love and grief? And I'm going to make the I'm going to make the sort of have the premise that understanding love can help us understand grief. And actually, it's probably just as hard or maybe harder to understand love. All of us know that from our daily lives, right? Than it is even to understand grief. But actually, attachment theory, promoted first in the 1960s by an English psychiatrist, John Bowlby, and really researched extensively around the world by clinical researchers, experimental researchers, neurobiological researchers, and even animal researchers, that's all helped us to really understand the fundamentals of attachment theory still being researched. But this is a theory that posits that the motivation to form love relationships, close relationships, is actually part of our biology. And the functions that these relationships serve in human lives across really all different cultures is that they help us feel safe and taken care of. They're a safe haven for us, and they're also a secure base from which we can go out into the world and do new things, learn new things, perform in various ways. And they help us feel confident in doing that. And they also share in the successes that we have when we do this. And those are very, very important functions. But in addition to that, these relationships, or more precisely, the way that we internalize them in our brains, have important regulatory functions that are, some of which are listed on this slide. And each one of these checks that I have here have at least one research paper research study behind it, often more than that. So this is very important also. In addition, the attachment system is linked to our natural inborn kind of biological orientation towards caregiving and exploration. So what happens to this system when a loved one dies? And the answer is that we have a lot of reaction. We have a big reaction to the separation and loss of an attachment figure and also of a caregiving person. And when these systems are affected in this way, exploration is shut down. And actually what you can do is map this reaction directly onto grief symptoms. And this is why we say that grief is the form that love takes when someone we love dies. It's one of the reasons we say that. So what we're going to say is that people often react strongly to losing someone close. I think we all know that, but we also adapt. And, again, Christy talked a lot about adaptation, and Steve really did as well. And what I will say is that we make the assumption in the work that we do, and this is supported by research data of various sorts, that people do naturally adapt to the loss of a loved one in particular, but to things in general. I mean, that's what living beings do. We adapt. And so we make the assumption that people will adapt even to the most painful loss unless something gets in their way. Often it's ourselves that get in our own way, but sometimes often also it's something in our environment, especially our social environment. So basically, adaptation in the way that we think about it is fairly simple. It really involves accepting reality and restoring well-being. So that's what we mean by adapting, that we restore well-being. That's kind of at the heart of it, but also we do that in a context in which we're really adapting to the reality of the changes that we've experienced. So grief is going to emerge in this kind of acute form that we've been talking about, and then it's going to find a place in our life as what we call integrated grief. So grief essentially is transformed. You can think of this as it being transformed as we adapt to the loss. And there's one of my favorite ways of really understanding this is from a poet, Denise Levertov, who maybe will make that poem available to you as well. And it's just a beautiful way of saying it. But this is really what happens. But keep in mind that integrated grief, actually, it's usually softer and quieter, but it's not always so, because grief remains a little bit messy. It remains sort of triggerable in a sense. So we always work, when we work with people, we always talk about difficult times, we call them. These are calendar days and or life events that are particularly triggering for people. Another thing that's important is that there are some grief elements that are, again, very natural, but that they're actually natural stopping points where we can stop and consider what's happened and consider why we're having these kinds of thoughts and feelings, and then learn something. Very often we can learn something from that. But if we don't do that, if we don't stop, if we try to ignore these, or we can't kind of figure out a way to learn from them or resolve them in some way, then they can derail that. This is one of the things that can get in our way. For example, some of the counterfactual thinking, in a way, it's what Steve was alluding to. Another way of saying that is counterfactual thinking, how things could have been different, about all those people who can't understand, to this day, they don't understand how this happened, why this happened. They keep thinking about why it didn't have to happen. I think that's really what he's saying. And that's a very natural response, but we do have to come to terms with it. And if we don't, this is what happens. We develop the syndrome of prolonged grief disorder. This is the ICD criteria, and really, again, pretty simple. It's the persistent, pervasive longing, yearning, or preoccupation with the person who died. So that the kind of center stage role that these people take in our lives before they die, but especially right after they die, they just fill our minds. That actually persists instead of gradually finding a place in our lives, the grief and the loss itself and the person who died finding a place in our lives that isn't so center stage. It just stays there. And that's associated it is always associated in prolonged grief disorder with additional evidence of intense emotional pain and impairment in functioning. And just to let you know, prolonged grief disorder, as I said, is in the final stages, we think, of approval for being entered into the DSM-5 formally. And one of the stages of this process of doing this was to get public comment, which happened last April and May. Some of you may have seen that and may have contributed, but now that changes have been made in these. So this is the prolonged grief disorder criteria that were on the website, but it's basically essentially the same as ICD-11. So again, both Christy and Steve mentioned risk factors that increase the risk of PGD, but I'm going to insert the derailers in the middle of that, because the risk factors, as we see it, act by increasing the chances that those derailers, which are almost always going to be present regardless of how the person died or when they died or who died. I mean, almost always we have some of these. And these are some of the ways that risk factors increase the chances. These are the kinds of risk factors that they talked about that increase the chances that those derailers get a foothold. And in COVID, I'll just mention, we all know that the way these deaths are happening, the contexts of the death and the early grief, and some of the consequences of these deaths are all comprising risk factors for PGD. So there is likely, people are saying, and I think this is probably true, going to be a sort of second epidemic, actually, because there's so many more bereaved people than there are even deaths, and we are seeing so many deaths from COVID. And so people are talking about this as a sort of secondary epidemic of the pandemic. So let's talk about how to approach the treatment of people who are struggling with grief, really at any phase of this process. So people who are really struggling early on and want help, we provide that help. And of course, then later on, when we start seeing complicated grief, or what we're now calling prolonged grief disorder, what we've seen over and over with that is that a lot of times the usual strong supports that people get in the community, including sort of ordinary grief support groups and people, there's some wonderful support available in early grief. We do provide it, but there's lots of else. But when you start to get into the prolonged grief disorder, the way to help people seems to narrow because they don't seem to get help from the usual early grief sources. So what we're going to do in this approach is to work to foster adaptation to loss, namely accepting that reality and facilitating well-being, and also to find and help people address those derailers. The way we do this is to work sequentially with a planned sequence of 7 core procedures with 4 foundational premises underlying this. The first one being, these are ones that I've really talked about, that we make this, in our work, we're making the assumption that grief is a form of love that emerges naturally and generally finds and can find and will find a place in our life if we can adapt to that loss. And that adaptation will progress naturally if it's not impeded, that everyone grieves and adapts in their own way. So we're not going to tell people how to do that. We're simply going to try to sort of free them and facilitate that process. And importantly, we don't grieve well alone. So these are our 7 core procedures, and they're associated with what we're now calling healing milestones, which I'm going to talk to you about in just a minute, or show you what they are. But these procedures are also, we train people to do these, we train clinicians to do these. We have a lot of information about them on our website, but they seem to be helpful to really a lot of people, which I'm going to show you the data that supports that in just a moment. So we developed this treatment and then asked the question of whether we could actually help someone who'd been suffering for years and years. And actually there is evidence that a very small proportion of people do gradually get better. Even if we don't do anything, they do gradually, very gradually over time, seem to resolve some of the derailers and move forward in their grief. But for the most part, that's very much more difficult to do. And over 5 years, 10 years, even sometimes longer than that, and I guess we're seeing that, Mary, in the 9/11 survivors, very understandably, it doesn't really help. So we asked, could we do this in 4 months? And the answer in 3 large NIMH-funded studies conducted pretty rigorously with a total of 641 randomized participants showed that 71% of the people who received CGT, the complicated grief treatment, compared to 44% of the controls, which were always proven efficacious, highly effective treatments for depression. So this is one of the issues about depression, is a treatment for depression just doesn't seem to help these people. So we measured outcome, our main outcome measure was this clinical global impression measure, which was done by independent evaluators, but who were also clinicians. And what we found was those results that I showed you. And then we also looked specifically at the role of antidepressant medication. And what you see in this slide is that there's no difference between the antidepressant treatment and placebo in people who just got that. But when we also added CGT, there was also still no difference between citalopram and placebo, which was kind of a surprise to us because we thought that adding antidepressant medication might actually make the response to CGT even stronger. But with depression symptoms, interestingly, we found in this group no difference between citalopram and placebo until we added CGT. In other words, if we also address the grief, then citalopram did significantly help depression symptoms. It didn't help the complicated grief symptoms, but adding citalopram for those people who had both depression and complicated grief, or as Steve was pointing out, was many of those people who had complicated grief in the 9/11 sample also had depression. And in that situation, it's clear that antidepressant does help also. Just a few other comments about this, and then I'll bring this to an end. So first of all, there's no difference in our study between older adults and the overall results. In our overall, we had one study focused on older adults, and they were age 50 to 95 or something. The mean age was about 66. Also, there's no difference between a violent death and a natural death. The outcomes for those, absolutely no difference. And they're actually, in our work, the response to violent death is a little bit better to CGT than to natural deaths, even though that's not a statistically significant difference. Suicidal thinking, which is very common in people with CG, with complicated grief. These data are from this first session and it's just the past week. You can see that about 30% had suicidal ideation in the first week of their treatments, and that reduced dramatically with CGT, and it was not affected by the antidepressant. And lastly, I want to just comment on the fact that we had 79, too few, but we did have 79 Black participants in our studies. And we looked at the difference between the outcomes in the Blacks and whites. And as you can see, this is the data from two studies. The previous study we published separately and was similar to this. Blacks had a slightly better outcome than whites. That's not a statistically significant difference, though. So basically, what we learned, I would say, is that we want to provide validation, support, and guidance. And the guidance comes in the form of working through these 7 healing milestones or the 7 procedures that I showed you. But validation is obviously, the normality of grief and adaptation to loss, and support as people need it. So the healing milestones is an acronym. Really, this is not the order that we provided these in, but it is useful. So the first one is that you want to honor your loved one and yourself, and do this in particular by exploring and connecting with your own interests and values. And that, again, echoes back to Christy's and Steve's presentations. You want to embrace emotions, both the painful and the pleasant ones. Neither is too easy sometimes, but also to learn to ease that emotional pain, something Christy also mentioned. You want to be able to accept grief and let it find a place in your life and not judge it. In particular, not judge whether you're grieving too much or too little. We consider grief to be the natural response to the loss in the moment, the way that you're experiencing it in the moment, and that will change as you adapt to the loss. But whatever it is, that's what it is. We don't try to change grief at all, and we don't want people to be judging grief. The third, healing, the L stands for living with reminders of your loss and allowing them to be bittersweet. The I for integrating memories of the person who died into your life and let them help you learn and grow. To be able to narrate a story of the death for yourself and to share with others. And maybe it's not one story, maybe it's several stories, but that's really a way of saying, a way of understanding and accepting the loss, the event, the death that led to the loss, so that you can accept its reality, really. And last, but certainly not at all least, one of the most important is to be able to gather others around, to let them into your life and let them support you. We also there are also stopping places that can and sometimes do derail the healing process. I won't walk through these, but we talked about them earlier. So in summary, we are saying that grief emerges naturally after an important loss, and most people adapt to even the most difficult losses. That it's important, very important, not to be judgmental about adapting or about the grief itself or about the loss, and also to be able to seek and savor positive feelings when dealing with a loss. And what I didn't focus on, but it is in our derailers acronym, is survivor guilt. And no one has really mentioned that yet. So I want to point that out, because survivor guilt, I think, is pretty much universal after someone close dies, but really after we learn about anybody's death. So I personally think it's one of the problems that that people experience in supporting other people, because you feel kind of uneasy that you haven't had such a loss, and that uneasiness, that discomfort, that sort of feeling that there's something, it's not right somehow, that's what we call survivor guilt, when someone else has died and you haven't, or when someone else has lost someone and you haven't. So that can make it hard to support other people. It can make it hard to support yourself. It can make it especially hard to have positive things in your life and positive emotions in particular. And lastly, just a reminder that COVID-19 deaths that we're seeing, the ones that occur because of COVID-19 and also the ones that occurred during the pandemic, have many elements that are likely to be especially challenging for people. And so we need to try to help them. And the way, actually, what I use as a sort of lodestone, in a way, a guiding light as I do the work that I do, is the serenity prayer, which is that we all need to find ways to accept what we can't change and change what we can, and very importantly, figure out what's the difference, because that's not always so easy. So I will end at this point and turn this back over to Mary, and thank you so much for your attention.
And why don't we invite all of the panelists up? Kathy, thank you so much for your presentation. I think these two areas of resilience and bereavement are so important, and to know about it in a proactive way so we can help, guide people when something happens. There was a lot of focus on trauma after 9/11, but I think very little focus on the bereavement. And, in my practice prior to 9/11, one of my big pet peeves was general practitioners prescribing psychiatric medications to try to help people along. And that went rampant after 9/11. So I think the more people can learn about how to build resilience, how to recognize grief, how to find those supports and what is really helpful, and then to have the resource as you're providing, Kathy, and your work with complicated grief, to know what it is, I think is really half the battle, and being able to come up with some solutions. And we ran over, actually, and we could probably have days, a day-long presentation with the three of you, but I know you wanted to say something, Kathy?
I do want to just say one quick thing, which is that there's a lot of controversy about the prolonged grief disorder diagnosis, and it's understandable because we do not want to pathologize grief. However, for exactly the reason you just said, Mary, the reason why people didn't focus on grief, I think, is because there's no diagnosis of grief. There's diagnosis of PTSD, and and that's been very important and not that long-standing. So I think we should applaud the diagnosis and be careful not to pathologize anybody.
Well, I wrote my letter of support, so
Okay, great.
But thank you to each of you. It's just such an informative presentation, and I'm hoping that we can invite you back where we have more interactive conversation. We actually had a lot of chaplains on the listening in today, and they were giving you a thumbs up, that they're out there too doing the work. So so we'll have to continue this on at a later date.